to Derms on Drugs, a video podcast brought to you by Scholars in Medicine, the best educational platform in dermatology, which also happens to be provided to healthcare providers at no cost. All you need is an NPI number. Derms on Drugs is where cutting-edge derm meets hit or miss comedy. I'm Matt Zyrus, and each week I'm joined by my residency buddies, Dr. Laura Ferris and Dr. Tim Patton, to use our 60 years of combined derm experience to discuss, debate, and dissect the hottest topics in dermatology. It is everything you need to know to be on the cutting edge of derm, and it'll be the most fun you've ever had while actually learning something useful. New episodes drop every Friday on Scholars in Medicine, Apple Podcasts, Spotify, and anywhere else you might happen to get your podcasts. Now, I do want you to know that we do have a video component to the podcast. So if you want to watch, we actually do show the slides and visuals that are most crucial from each of the articles. And we've got additional bonus content over on Scholars in Medicine. So you're going to have to head over there if you want the absolute full episode where we're going to talk about one of the coolest things I've seen in a long time for treating skin cancer, and it should be coming to the U.S. in the next year or so. But for today's episode, we've got a great topic lined up for you. So you've probably heard some about this image-guided superficial radiation therapy, which is an in-office procedure that some dermatologists are starting to add. It's showing up more and more in our literature. Well, we're going to go over two of the best recent articles about it. But then for our deep dive, we've got on two radiation oncologists with a lot of experience dealing with cutaneous oncology. And we're really going to get into the nitty gritty of if this is something that's really appropriate for us to be doing in dermatology offices. So we are going to start it off with me kicking it over to Dr. Ferris. Dr. Ferris, what do you got?
Thanks, Matt. So I have a paper recently published in BMC Cancer, Maloney et al., title, Updated Results of a 3,050 Non-Melanoma Skin Cancer Lesions in 1725 patients treated with high-resolution dermal ultrasound-guided superficial radiation therapy, a multi-institutional study. Okay.
Nice snappy title.
Yes, it is. Exactly. Rolls right off the tongue. So this is so just to sort of give you some background. So this is a retrospective chart review from that is sort of a follow-up of a 2016 to 2020 retrospective chart review looking at patients treated with IGSRT, which will be a faster way to say this, and looking at their outcomes. So first of all, what is IGSRT, or what does image guided mean when dermatologists are giving radiation therapy? So I think our guests will be able to tell us what they mean when they say image guided. So the image that's used here is 22 megahertz dermal ultrasound and color Doppler to visualize superficial depths of the skin. And so, this lets the physician visualize the lesion prior to, during, and after treatment to sort of adjust treatments as necessary. So basically, in June of 2021, there was a published study that retrospectively looked at, about 2,900 lesions from 1,600 patients, and they looked for rates of local control. And they said, local control rates were extremely high, 99.3%, with a mean follow-up of 16 months. And so what this study does is it adds another 93 patients with an additional 133 lesions, adding in basically results from another derm practice, and also updates the results with longer follow-up. So we have over 3,000 lesions treated from 2016 to 2020. So what were these lesions? These were all stages. These are basal cells and squamous cells from in situ tumors, T1 to T2 actually were the thickest studies. So this was not a prospective study. This was retrospective. And interestingly, if you look at how they followed up patients, in some cases, they actually, looked at data from charts, but they also, for some patients, did not actually have that. They did not manually extract the data, but they used this algorithmic analysis from a healthcare company called Sympto Health. So this was an IRB exempt study. Why does that matter? It does mean that when you have an IRB exempt study, you're sort of stuck with using the data that's there. You can't go back and say, let me call that patient and see, were they treated anywhere else? Was there a recurrence or anything like that? Okay, so that's just sort of a little background. So in this study, we can
Wait,
see
wait,
that patients.
Ferris, I got to ask, does that this algorithmic follow up thing sounds to me like baloney? I know nothing about it, but as you just described it, it sounded very suspect to me. Do you do you do you think of it as suspect, or do you think it's legit?
I think it's not the typical way that we do oncology studies. So, I think it means that, it's a large sample size, but I think it means that you're not necessarily going to have, I think about it when we talk about studies done in Trinetics, right? We say this is a big database, the advantage is the large size, but we don't necessarily get the same granular level of detail that we would, for example, if we did a chart by chart review,
Okay.
just to
Okay.
sort of think about it that way. Okay, so so basically what they said is once treatment ended, patients were evaluated for 2 to 6 weeks after completion, and then every 1 to 6 months after. So in this study, patients, the median follow-up was 25 months. The mean, so looking at, the mean number of fractions, or meaning the number of treatments that a patient had, the mean was 20. So they came in and had 20 different fractions of radiation. The total dose received, the median was 5,184 centigrades. Duration of treatment was on average 7 weeks, and the median size of the lesion was 1 centimeter. Most of these were basal cells. Most of these were on the head and neck. And so, looking at their results, they had their very high level of local control. They had 23 recurrences out of 3,050 lesions. So that's an absolute local control rate of 99.2% of the lesions that returned. 15 were basals, 7 were squamous cell carcinomas, and there's 1 squamous cell carcinoma in situ. They did look at toxicity, and so they looked at, if you look at RTOG, acute toxicity, so that's radiation treatment oncology group, and so they look at it by grades, and so most of these were grade 1. So there were 1,818 RTOG grade 1 toxicities. There were 4 that were grade 4, and then so, not, those were a low number of grade 4 toxicities. However, they did note that, they didn't have a procedure to record RTOG grading and toxicity. So, there's going to be some missing values, and there's going to be some missing data in this. We also really didn't get any report of what those adverse events or toxicities were. So, the authors said, when we compare it, now this was a retrospective study. We don't have a control group. We don't have a group, for example, that was controlled with maybe Mohs surgery or topical therapy or, anything else. So they did compare their results to some older guided SRT studies where they had the radiation therapy but not image guidance. They reported one by Armin Cognetta's group that had a 2-year recurrence rate of about 2%. And so they said, well, our local control was a little bit better than that, although it's hard to do, those are 2 very different studies and different modalities, and of course not, randomized. They also compared their results to another study, Hernandez, Machin et al., and said that their 5-year absolute local control rates were 94.4% for basal cells, 92.7% for squamous cells. So, so basically the authors make the point that the image guided seems to be better, and they suggest that we should consider superficial radiation therapy of some sort as a first line treatment. So, I guess one of the questions that I had looking at this was, we could say, all right, this is a pretty decent local control rate, but what were these lesions? These were things that were about a centimeter. They recommend not doing this for anything that has a depth greater than 6 millimeters because of the low penetrance of their 50 to 100 kilovolt energy. Limitations in the covered, surfaces. They suggest you shouldn't do this if you've got concavity of greater than a centimeter. In that case, a flap or might be a better option for this patient. You might want to do that. So I guess my question is, like, is this a huge unmet need that we have to treat lesions that are thin, small, non-melanoma skin cancers? There's maybe something we could have treated with DNC.
So what I'll be interested in, because at initial glance, like, shit, I mean, it's almost 100%, and it seems like this would be great for like the tiny little BCC on your nasal ala or your, margin of your eyelid or somewhere that's a real pain in the butt to do treatment, maybe. But I'll be honest, I just don't know enough about like how safe this, like, that's, I'm excited to have our guests on, and I assume this is pretty safe if they're doing it in derm offices, but I'd like to know a lot more about it.
Yeah, I think it'll be interesting to have a discussion of what I mean, do I know what 5100 centigrades really correlates to? Not really, like you make the point of eyelids, they're tough, but that's also really thin skin. I mean, and there's an eyeball under there that maybe you don't want to radiate. So, I mean, I think it'll be kind of interesting to see what they think about that.
Yeah, no, because it really is a fascinating, to get out of the cost effectiveness of it and all that. But just if I had a tiny little basal cell on my alar rim, I don't know if it wasn't too hard to drive for 20 visits, I probably wouldn't. I'd probably consider this instead of getting a paramedian forehead flap or something. Well, let's from that point, let's go on to our Dr. Patton. Let's go on to our next article here.
Do you have any thoughts on this paper?
Was this, so were these cases all done by the same group? Was this multi-center? Was it one?
It was multi-group. I think it was about 7 practices.
Okay. Because I'm wondering, like, the lead author is
cases they did, right? It's not like here's a consecutive series of every basal cell that we saw or every squamous cell. It's the cases that were done.
Do these guys really know? The lead author is a radiation oncologist. He works for Skin Cure, and that's who makes the Gentle Cure system that's marketed to the derm offices. Is he really good at picking out the lesions that he knows are going to respond to this? And is it, is he way better at selection than giving this to just any random dermatologist and saying, hey, now you can treat skin cancers too? Is there something like that involved? I just had a lot of questions. Like, what didn't he treat? You know what I mean?
Presumably, so that's one author, but I mean, presumably in a multi-center study, he's not picking all 3,050 lesions, right?
That was the question I had.
Yeah.
Right.
So I think there's going to be a lot of variability in who picked the lesions and did the treatment, things like that.
All right. So my article was from January 2025 issue of Skin, the Journal of Cutaneous Medicine. It's titled "The Role of Image-Guided Superficial Radiation Therapy in the Treatment of Non-Melanoma Skin Cancer" by Zacharia et al. For this paper, the authors performed a literature search that produced 87 articles about IGSRT and skin cancer. Of these 87 papers, 12 papers made the final cut and were reviewed and used to develop consensus statements about the use of IGSRT for skin cancer. I know it is early in the year, but I'm ready to award this paper the most bonkers article of the year. The M-Day. It's a Derms on Drugs exclusive. I don't know if you guys know this or not, but there are physicians that undergo years of training working with the type of radiation that's described in the article. They're called radiation oncologists. It's right there in their name. You know how many radiation oncologists were involved in the development of these consensus statements? 0.0. How did this get published?
Is there a confidence interval on that? Yeah.
No, I'm not saying they all need to be rad oncs, but at least get one, for crying out loud. If a consensus paper was published about Mohs surgery for an MSc and it didn't have one single Mohs surgeon on it, would you even read it? This article was bonkers. All right.
I
Now,
never, yeah,
enough about all that.
I gotta say, I never thought about that. When you put it that way, yeah,
I couldn't believe it. Yeah, let's go on. All right. So, and
all
I think that influences a lot of these consensus statements and how they were voted. Uh, the authors created 10 statements. 8 received a unanimous 6 out of 6 votes for adoption, and 2 received 5 out of 6 votes for adoption. Strength of the statements was either A or B. I'm not going to go through all the statements. Maybe when we bring our radiation oncologists on, they can address specific ones. Most of them are pretty like banal, like SRT is well-established modality for the treatment of NMSC, dependent on individual patient characteristics. I mean, sure, yeah, that's going to get a 6 out of 6 vote. Nothing too crazy. And most of them were like that. Some of them I was like, well, I don't know about that. So SRT, including IGSRT, can be considered a first-line treatment for NMSC for appropriately selected patients. That didn't seem too crazy, but if you read the text under that particular statement, the authors, this is a quote, the authors concluded that IGSRT outperforms Mohs micrographic surgery for NMSC based on statistically significant superior 2-year recurrence probability. Bam, they said that. This is better than Mohs.
with a
That's
net
in the
rate
paper.
with non-random. It's not like they were randomizing. Hey, Mohs or IGSRT, like 97, 99 point whatever sounds great, but those were
Yeah.
not. Oh, whoa.
Yeah, they tried to walk it back and they're like, oh, however, but no, that sentence is in this paper. So, like, if not that patients are going to be scouring the literature, but if any of them came to you and said, I got this thing that says IGSRT is better than Mohs, why would you recommend Mohs? Like, do we just say, you know what, those people were crazy that did that paper, just to ignore it? I mean, I don't know where that puts us, but let's move on. There was another one. I don't want to get. Patients with NMSC need to be offered all appropriate treatment options and should be part of the decision-making process. I mean, in a perfect world, but if you have a spot on the nose and it's a basal, I'm like, Mohs is the best treatment for you. I'm sending you to Mohs. I've never, ever, ever offered IGSRT. I've never acknowledged that that's even an option for the patient. Like, am I going to start doing that now? But whatever. The one that made my head explode, figuratively speaking, of course, because that would be messy otherwise.
Yeah.
Dermatologists are the most appropriate clinician to direct and administer. I mean, take that back. Dermatologists are the most appropriate clinician to administer SRT, including IGSRT. That got a 6 out of 6 vote. Have they all gone insane? Radiation oncologists are the most appropriate clinician to administer SRT, period. End of statement. No debate. If I wasn't doing this paper for the podcast, I would have stopped reading it right there, concluding that the Delphi panel was all high on the same fumes that the original Delphi oracles were exposed to. So that's where I'm stopping it. What did you guys think? I mean, I thought this paper was absolutely insane. Am I being unfair?
So I've my take is that, and I can't wait to have our radiation oncology colleagues on, is that IGSRT works in appropriately selected lesions, but it, it really makes a lot more sense. I agree that this doesn't make sense as something to me that's in every dermatologist's office, and that every patient we're gonna, talk about this as an option. Uh, Man, it just, yeah, my take is that it's a good treatment when it's used appropriately, and that they're trying to make it what is appropriate use become an extremely broad category, uh, which is why we had to have the appropriate use criteria for Mohs, come out 10 years ago, because you can't just use Mohs on everything. I think that's what we needed here. And that's what I was kind of hoping this article was going to be, was give very specific, hey, these are the 5 types of basal cell that you should really think about
Yeah.
this in. But no, it doesn't look like that's what they did.
Yeah, I have a hard time with, this is, superior to Mohs surgery without any data. This is a very, it's obviously a selected set of lesions from the first paper that we reviewed. I mean, most of them are basically, a centimeter. I also would not argue that I am the most appropriate clinician to direct or administer any kind of radiation. So I agree with you that that's a tough one to get behind. I mean, look, I think I like the idea that there's multiple different modalities to treat patients with non-melanoma skin cancer. I get that there are patients for whom surgery is not a good option. But man, 20 trips to the office for radiation is also not nothing, and maybe not the easiest thing on some of our patients for whom we might think are not, surgery is not a great option. So, I think we just, as with all of these modalities, we need to think about who is the right patient, what is the right use, and make sure that it's not just like, well, it's the tool that I have here, so I'll offer it.
Yep. Well, with that said, let's introduce our radiation oncology colleagues. We've got Dr. Mowry and Dr. Patel, who I believe are both faculty at the University of Pittsburgh Medical Center, which is where Doctors Patton and Ferris got to know them through virtual tumor boards. So, Dr. Mowry, Dr. Patel, thank you for joining us today. Excited to have you on the show.
Thanks for having us.
So before we get really too far, just explain kind of the basics of like as a dermatology resident, I was taught once there used to be this old thing called Grenz rays, which like we don't use anymore in dermatology. That's pretty much the extent of the training I had on radiation therapy. Superficial radiation therapy, is it like what? Give me the basics of it compared to like shooting a beam inside somebody's head. I assume it's a very different thing from like real radiation therapy, but I don't know. So give us the lowdown here.
Traditional radiation, we use high energy. So radiation is typically light, and whether it's superficial or the what we do clinically for deeper tissues is a higher energy. So it's in the MV range, like megavoltage. So
Okay.
it's an order of magnitude, or higher, or 1,000 times more than our kV ranges that these superficial
Okay.
beams are. And superficial radiation, or kV voltage radiation, is not a new thing. We used to call it ortho voltage back in the old days, and they used to develop ortho voltage machines to treat skin cancers. It didn't have much. The advantage is it doesn't penetrate very deep, so you don't go through a lot of tissue. So in some ways it's advantageous, other ways it's disadvantageous. Both Dr. Mowry and myself, we use this in preclinical settings, kV radiation to radiate cells or for preclinical studies. And so it's not a new technology, but what radiation is doing is it's causing DNA damage, and cells can undergo mitotic catastrophe or cell death through radiation treatments.
So as a general rule, are these like could an office hurt the staff or the physicians with one of these things, or is the radiation kind of from you guys' perspective so pathetic and weak radiation that even if you like happen to be walking by the room and they pointed at an idiot pointed it at you and was like, zoop, oh, I gotcha, like you wouldn't care, like it was because it's such weak radiation? Or is it like, is radiation dangerous no matter what?
I mean, you'd have the X-rays that we get, like X-ray machines in dentist office. They're kV radiation, right? We don't just shoot that at people willy-nilly, and there's regulations around that. So, but relatively speaking, it doesn't penetrate very far. And I'm sure I have not used one of these machines personally, but I'm hopeful that they are developed so that it's not that radiation is being pointed outside of where your target is.
I think in fairness, these actually, like, a radiation technician comes to your office and administers it. So it's not like the dermatologist is, the one, administering. Probably like you guys have radiation technologists who help you, like you're not in there. doing it all yourself too. So I think that there is actually a radiation, I know that there is actually a radiation technologist who comes in.
And is there long term? So it also is somewhat reassuring to me that you said people have been doing this for a long time. Because, right, 100 or not 170 years ago, they were using radiation to treat acne. And then it wasn't till, decades later that, oh my God, that was a bad idea. These people are getting cancer all over their face. Like, do we know that this type of radiation it's not going to be 20 years from now? Oh my God, we got rid of that basal cell 20 years ago, but now you've got this horrible squame or Merkel cell or whatever. Do we have reasonable long-term safety data on this?
We do. I think the main thing to highlight, though, with any radiation, whether it's kilovoltage or megavoltage, is there is a risk of radiation-induced cancer or malignancy. So with every patient that we consent for radiation, we talk about that risk of radiation-induced malignancy. So I've seen patients treated for one skin cancer who get another skin cancer 20 years later in that spot where it was cured, and it was probably a radiation-induced malignancy. So that same phenomenon can happen whether we're talking megavoltage or orthovoltage. And still, you mentioned earlier, what if we were treating someone's eye? Well, when Robbie and I treat someone's eyelid, we put a lead shield, like contact lens, in their eye to shield their eye, because you still are going to have potential for cataracts or, damage to the retina from the radiation. So there's certain precautions that we can take for certain things like that. But there's nothing we can really do to reduce the risk of radiation-induced malignancy. It's a small but real risk, regardless of the energy of the radiation being used.
So Ravi and Yvonne, do you guys are skin cancer patients referred to you like as primary treatment? Like a patient says, I don't want surgery, I'm going to talk to the radiation oncologist, and you guys use SRT for those patients?
We don't use SRT, but we can use electrons, which is similar. And they don't have much penetration. We put on a bolus to make sure that the skin gets proper dose. As Dr. Mowry mentioned, if it's in a tricky location near the eye, we protect the eye with eye shields. Sometimes, like for the nasal mucosa, we can put things in to protect the other nostril.
One of the consensus statements was that IGSRT is way better compared to electron beam. Do you agree with that, or any issues with that?
I mean, it's never been compared. I mean, we just have retrospective data, right?
Yeah.
So they used to have like radoncs used to have ortho voltage, but we stopped using it because electrons work just as well. And so it's, as I was saying, this is not a new technology. It's an old technology packaged in a new device.
So the technology, like an SRT machine from 20 years ago and an SRT machine now, like you would not say, oh yeah, the technology in 20 years has been so much better. These machines are just, they blow these old ones out of the water.
I'll be honest, I've never used the old one or the new one, but I've used KVs, and the X-rays are the same, right? A KV X-ray at 50 kV or 100 kV isn't going to change over time. The thing that they've packaged into this one is that ultrasound.
Yeah, what do you think about the image-guided part of this?
I'm not. I think it's probably for billing, because you can bill the IGRT, which we in Radonc know that there's a billing code for that. Typically, we treat to a depth for these lesions anyways. And there's also a margin. With radiation, with Mohs, you get right to the margin. You don't go extra too much, right? With radiation, we put an extra margin on. That's one of the things that we do, because we are trying to get those cells. Oftentimes, we're radiating post-op after Mohs. We're trying to get those nerves with PNI and get that margin around the surgical area.
With this kind of sort of ortho voltage and superficial radiation therapy, how much does it matter the schedule? So meaning, hey, this week I can get in twice. Oh, next week I'm going to be out of town and I'm going to have to skip a week. Then the week after that I can come in 3. does it does that affect treatment efficacy, or is it like, as long as you get in at least like once every 2 weeks until we get in year 20, you'll be fine? Like, does it matter?
It's a great question. It matters a lot. And so that is one of my concerns, is that really would need to be emphasized to patients, like not having treatment breaks, because treatment breaks are going to allow more time for repopulation and for radiation resistance to develop. So when we treat these patients, we are giving them daily Monday through Friday treatments. Sometimes we will, particularly in elderly patients, will really hypofractionate, where we'll give a larger dose of radiation and we'll give it just twice a week. But it doesn't seem like that's being done with this. It seems like these are usually kind of smaller, 2.5 gray per fraction times 20 treatments. But it's going to be really important for efficacy not to have treatment breaks. And I think to the image guidance portion, I think that the ultrasound is essential when it comes to particularly planning and selecting what energy you're going to choose, because higher energy is going to be able to go to greater depth. And you're going to also want to make sure, as Robbie mentioned, we add margin. Well, when we treat with electrons, there's a little bit more penumbra, the radiation goes out a little bit further. With orthovoltage, it's a rapid drop off. There's no forgiveness. So if they aren't treating laterally or giving enough margin around the lesion, they're going to miss. And then one of my biggest concerns is about perineural invasion, because that's where you're going to have some microscopic disease further out from the lesion you can see. And if you've got that sharp dose fall off from the orthovoltage, you very well might miss. But I think getting the ultrasound to know the depth and to choose the energy to make sure that your beam is going deep enough is going to be important. But what Robbie and I do for our planning is we typically do CT-based planning. So we get real three-dimensional and we map out if it's post-op where the tumor used to be, if it's, curative intent without prior surgery, we'll map out the disease, we'll add margin. We'll often treat to 2 different dose levels, higher dose to the gross disease and a lower dose to a larger area where we're more concerned about microscopic disease. And then our image guidance is usually a cone beam CT scan, again, 3-dimensional, lining things up every day. Sometimes, we're doing like matched KV 90-degree images, but usually we're doing CT scans. So our image guidance is very different from the image guidance that's being done with ultrasound.
How often do you image, like to sort of refine your plan? Like I think with this, it's done every single session. Is that?
We do. We image every before each treatment, typically, but we don't always refine the plan. When we see a change or we need to, we review and we do refine our plans as needed.
Where that most often happens is post-operatively, where there was a lot of swelling and there's kind of anatomic changes that we need to replan for. But you're typically not going to see a major change in the tumor size during treatment to require replanning during treatment.
All right, so this is probably a somewhat it's obviously a very location-specific question. So how far and few between are radiation oncology places? So one of the benefits I could imagine this thing being, hey, there's 2 Mohs surgeons in, a city the size I'm in Columbus, Ohio. We're a 1 million people city. Hey, there are 2 Mohs surgeons that have one of these. They, really went through some training, really know what they're doing. If you have a patient you think it's good for, send it to them. And it would be nice because, right, the Mohs surgeon's office is usually easy parking, easy in and out, like the blah, blah, blah. With radiation oncology, is it like something that you're going to have to all departments are like in the basement 100 yards below the surface, so you're not is it super hard for people to get in and out of radiation oncology places? And are there many community hospitals that have them, or is it you got to go downtown to the mothership to get stuff radiated?
So we have 26 satellite centers at UPMC. We cover Erie, Beaver, Northwest. We radiate patients who have breast cancer, prostate cancer. They have to come in for daily radiation. Sometimes, Dr. Mowry treats head and neck at 35 treatments sometimes. So they have to be in the community, and there is radiation oncology at most community sites.
I think rural areas, just like any, some rural areas are undercovered, but generally speaking, there's a good distribution of community radiation oncology sites that are comfortable treating skin cancer. But, very rural areas where you probably don't have most surgeons, you probably also don't have radiation oncologists, unfortunately.
And will the vast majority of radiation oncologists and radiation oncology sites be able to do orthovoltage like this? Or is it like, oh, the vast majority couldn't, there's, while UPMC's got 35 satellite locations, only 2 of them could treat, with superficial radiation therapy?
Any radiation oncology center will have electrons, or almost universally, but very few are going to have orthovoltage. But as Ravi was saying earlier, electrons work just as well. I don't believe what this paper says. I think that's a selection bias from a retrospective study, that the patients who get selected for the superficial orthovoltage radiation have smaller, less complex tumors. And that's probably why there's a difference in recurrence rates. But any radiation center should have electrons and should be able to treat skin. I mean, in residency, Ravi and I specialize in this, but in residency, every radiation oncologist learns how to treat skin cancer. And I just want to put in one other plug is that it's not just, Ravi and me, we mentioned the radiation therapists are at the machine, but we also work with physicists and dosimetrists. It's a whole team, that I'm a little bit perplexed as to how much that whole team is involved in the planning. Radiation physicists look at every plan and do quality assurance. When I treat a skin cancer, I usually do a dose check on the first day. We've got physicists who come in with diodes and we measure. I suspect those sorts of things and the daily quality assurance that we do on our machines, daily, weekly, monthly, annual. I'm not sure that same kind of QA that's really radiation physics driven is being done in sites that just have these orthovoltage machines. So that gives me a little bit of another pause about just what the QA is on this.
Yeah, I'd like to just follow up on that point. From a physician standpoint, I think, obviously, knowing the margins and everything, dermatologists know that probably better than I do. But all the support staff and the QA, these machines go down. They can deliver the wrong dose. You can have a misadministration. We've seen how much our radiation machines, they go down from time to time, and you can have a bad mistake. And even the ones that we have in lab, they go down with these KVs. So you do need to make sure that you're doing things properly.
It's interesting. This is reminding me of some conversations I've had with Mohs surgeons over the years, some of whom who have been like, well, my tech's not that good, and I'm not sure that I'm that good at reading this. These are usually people who are not they kind of do Mohs, but are not a Mohs surgeon. And I haven't had a conversation like this in 15 years, but 15 years ago, well, it's just, Mohs isn't that, you get in there and the inflammation's going to get rid of it anyways, whether you could, and it's it makes you say, well, okay, so Mohs isn't that and then you talk to what I would call a real Mohs surgeon, and they're like, oh my God, no, are you out of your mind? If you're just willy-nilly, I probably got it, I can't really tell. So this sounds like it sort of falls into the category of in derm, there's a common sort of debate among people who went and did a weekend course on how to do Mohs surgery versus people who did a 1-year fellowship, and that yeah, for some lesions you probably can be fine if you did the weekend course, but overall it's not really the same.
You guys have probably seen people who mistake a Merkel as something else, and they do a non-oncologic surgery on that, and then you guys have to clean up afterwards, and we have to radiate afterwards. I know in the Pittsburgh area, it's a plastic surgeon that has this at SRT, so it's not going to just be dermatology clinics. It's going to, I think, a lot of the motivation behind this is it's marketing and a financial incentive.
Right. 20 visits where you don't, even if you're only getting reimbursed $120 a visit, if you as the physician don't have to do anything, you're basically getting $120 for doing nothing. You can still, it's just extra money. It certainly does seem like there's some financial incentive there. Now, one other question for you guys. In neither of these articles did they really talk much about the healing phase. So with electrons or superficial radiation, like, do the lesions ulcerate? Is it like this horrible thing, or is it like, oh, it gets a little red and it might scab and crust a little bit, but it's no big deal? Like, what do you expect when you get somebody for skin cancer? For whatever reason, they've had 9 surgeries, they're sick of surgery, they don't want another. What do you tell them about kind of the healing process?
So radiation dermatitis is an expected toxicity. They have very few grade 2s, which is surprising because when your target it doesn't matter of whether you have orthovoltage or electron or megavoltage. It's the total dose accumulated by the tissue. Radiation absorbed dose isn't dependent on what type of beam you use. It's just that's more on penetration.
Okay.
And so they say they have a lot of grade 1, they don't have much grade 2. That suggests that they're either waiting a lot of time between their fractions, or they're not documenting it correctly. It's hard for me to know which one on a retrospective study, but you do expect radiation dermatitis, usually by a few months. Like I see them for a 2-3 month follow-up that's healed. Sometimes you can get more significant radiation side effects. I have some patients who've had cellulitis that we've had to start on antibiotics. There are some studies looking at the microbiome on the skin and effects on radiation dermatitis as well.
It's typically just kind of a red, itchy, dry, peeling type thing. And the kind of size of tumors that are going to be treated with this, they're going to be so small, you're not really going to get ulceration. I mean, I've treated things that are 5 centimeters, 8 centimeters, big masses. When you treat those, then you're going to get ulceration, and the tumor's gradually going to come mush, and you're going to get a reaction around it. But for these things, it's going to just be like a little bit of scabbing, peeling, and then the scab falls off, like very minimal toxicity.
Okay. Pat and Ferris, you guys got anything else? I think I've gotten my questions answered. Pat and Ferris, you guys got anything else before we kind of switch to our next topic?
I was curious if a patient does come to you and they say, I don't want to get cut, I hate anesthesia, I'm nervous, I like this radiation idea. Do you try and talk them out of it? I mean, do you kind of say like, we got to be honest, like Mohs works really, really well. It's one treatment. How do you approach that patient?
So there's definitely patients that I try and push more into surgery. If they're immunosuppressed, for example. Like I think radiation alone doesn't work as well in that patient population. If it's a small thing like this and they have had a lot of Mohs and they don't want it, I think that like for a 1 centimeter BCC, radiation also has a quite high, it's pretty effective. But, there are definitely patients where I try and push them into or convince them that they should get surgery.
But even in your hands, you would say you're going to be coming in for 20 fractions.
For the most part, there are some elderly hypofractionation trials that we can do. There was a study from Anderson, but most of the time I like to do 20, especially if it's something like the eyelid or nose. I don't hypofractionate those areas because there's at-risk structures. And again, we have methods to protect the eyeball and other nostril and things like that.
Yeah, for elderly patients, I'm finding myself more often doing 2 fractions a week, usually for 6 treatments, just because it's too hard for them to come in every day. But then those treatment each dose of radiation is much bigger than what we give if we give daily for 20 fractions. But when I see a patient, like the most common patients that I see are those that have had multiple Mohs and they just say they do not want to go through that procedure again. I usually still do try to convince them and say, I think local control is going to be slightly better. But, usually it's when patients get to us, it's because they've outright refused surgery.
What is the downside of hypofractionating?
There could be, go ahead, sorry.
No, go ahead, Ronnie.
There could be some increased risk of toxicity and cosmesis. Definitely, when we're looking at the eyelid, I definitely worry about because it's not been tested in that location, hypofractionated too much.
I worry about potentially more, just on that, worry about more fibrosis. And then in areas of cartilage, like the nose and the ear, there may be a higher risk of cartilage necrosis with a higher dose per fraction. So those are the kind of things to worry about. Though, where I trained, actually, we treated a lot of small basal cells in the nose with 4 gray times 10 every day for 2 weeks. And I was shocked because the kind of traditional, people think, oh, poor cosmesis with that hypofractionation and cosmetic outcome. I probably treated 20 patients that way and was always good. And I never saw any necrosis. So I think we maybe are overly cautious with the hypofractionation. And now I've treated a lot of elderly people with 2 fractions a week and haven't seen issues with poor cosmesis or necrosis.
And so that actually brings up one of the other questions I always got for superficial radiation therapy is if a patient, again, with a small basal cell on their nose or even their forehead, whatever, says, what is the absolute best cosmetic outcome? What am I likely to get it with? My take is that SRT might be a reasonably good answer, that it, compared to anything surgical, you're probably going, like, is it usually you can't even tell there was ever anything there, or does it, leave a fibrotic white spot or something?
It's a little bit unpredictable, I think, is the problem, because a lot of times you can't tell anything, but sometimes it's a little hypopigmented, sometimes it's a little hyperpigmented, and then sometimes you can get telangiectasias, and it's just hard to predict if people are going to get those. So most of the time you can barely tell anything. But I think in the hands of good Mohs surgeon, Mohs probably is going to give you better cosmetic outcome more reliably, because with the radiation, you just can't predict as much how exactly the skin texture and color is going to be after radiation.
Well, everybody, we are going to kind of end this part of our conversation, and we're next going to jump into talking about a really interesting therapy that's starting to show up in the literature called rhenium cream. And so this is basically a radioactive cream that you apply topically, and it also has some very good data on skin cancer treatment. Rhenium was the article that I did, and I went to the company's website and looked at their, the little spiel about how the stuff gets applied, and it actually looks like pretty cool. So it's been interesting to me. I don't think it's been studied a whole ton. So even in this article, I think it was, so there was an early trial of 53 patients who it worked in. In this one, it was 7 sites worldwide, and they had a fair number of patients here. Let me see again. Let's see their results. So sample size. I did look this up. So all tumors. So they had about 100, a little over 100 tumors. So not a huge amount of data on this topic yet. But the basic idea is you put on a special little sticker, kind of looks like Tegaderm, and then they take this cream and they cover the Tegaderm with the cream, and then you calculate how long you want to leave it on for, which is determined by how deep the tumor is, and that can be anywhere from like 20, 30 minutes up to like 3 hours. So the patient basically sits there, you peel the stuff off, get rid of it, the area is going to kind of turn pink or red, and then basically it might get a little scabby, but then the tumor's going to go away. And in a prospective study, so much better data capture than in a retrospective, they had 97.2% success. So 3 out of 106 tumors were not completely cleared at 6 months. Those tumors were, had partially resolved. So this has what I would call a reasonably small amount of data behind it at this point. But the idea of a single treatment, that you put the cream on and, you leave it on for an hour, give or take, and you got a 97% cure rate, sounds pretty darn good. Whether it's in terms of convenience and those kinds of things, it's better than anything else we've got, right? We could, in derm, we sometimes will treat with topical chemotherapy or topical immunotherapy, but then people have months of, ulcers and weeping and oozing. This has a lot of benefit. I think it looks like it could be a competitor for superficial radiation therapy in terms of the types of tumors you would take on. with the main benefit being it's a single treatment. First of all, prior to us bringing it up, is this rhenium thing like you two are, as radiation oncologists being like, what the hell are these dermatologists like talking about? Who the hell would ever put rhenium onto? Or is this something where you're like, oh yeah, it's been around for a while. Oh, there's an interesting use for it that I never really thought about. But what was your general take on this?
So I don't think rhenium's been around for a long time, but it sounds like they're doing low dose rate brachytherapy, which has been around for a long time. It's just they have a different compound.
Wait, what is brachytherapy? I generally hear I think of that as like putting pellets in somebody's prostate.
So there's different ways you can do brachytherapy. There's things like pellets. There's a company called Alpha Dart that makes a pellet that has some alpha radiation diffusing through the tumor. We also have something called HDR brachy, where you put catheters in over an area of skin, and the radiation delivers a dose over a period of time. Usually it's fewer treatments than 20, but more than one. There's different regimens. But basically what it's doing is trying to get the radiation just to the superficial part of the skin. But it's something that's been around for a while. I don't think rhenium, I haven't seen rhenium before in the past, but it's kind of the same concept of delivering radiation over a period of time.
So with brachytherapy being something that is not new, like, it sounds too good to be true, to be honest, right? Oh, you put it on an hour, 97.7%, and then you're done. You just go home. It sounds too good to be true. Is it? Yeah. What's your take?
I think I agree that this is not a good sample size. We need more data on this. I'm not sure if it's going to end up being much better than some of the other things that are out there. Probably also being driven by a company that has a product, as many of these things are.
Yes.
Whether it's clinically adopted or not, I'm not sure. I do have a little bit of I don't know how they're calculating the dose to the tumor. It seems like they're kind of making up times. I think you could find a way to do something like this with the proper physics and calculations. I just don't know if they're doing that right now.
If we took the do no harm perspective, I guess one question is we've reviewed a couple papers where they basically, it says if you biopsy a squamous cell carcinoma and you just observe it, 95% of them resolve on their own, right? So we probably do a lot of surgery for things that were likely these are relatively low risk tumors. We're not talking about doing this on the 8 centimeter, ulcerated perineural invasion squame. If a lot of these were probably going to go away on their own, and we know that it's probably safe to observe, and you thought, okay, if this is a cost-effective, really easy for the patient, put on some rhenium and then bring them back in 3 months and see if the tumor's there or not. And if it's there, go back and do surgery. And if it's not, see them in another 3 months and you're probably not going to recur. I mean, would that be maybe a consideration? Or do you think there's potential true risk, or that we might, irradiated tissues maybe not as easy to do surgery on later? I mean, I guess what's the harm? Could we ever look at it like that?
It depends on what. So it looks like they're getting 50 gray. I haven't done the calculations, but getting 50 gray in 3 hours seems like a lot to me. I don't know what you think, Yvonne.
Yeah, it seems challenging to reach that dose at that amount of time, but
I don't know if they're actually reaching that dose or how their calculations are, if they're leaving it on for a longer time.
And I will say my 30-minute to 3 hours, I asked AI because I couldn't find it anywhere else. I was like, how long are they leaving this stuff on? And that's what
they would have to leave it on longer. If you send someone home with something like this, I do have some concerns because what if you get a radioactive cream on a family member or something? That's probably not great.
Hey, Dad, the dog is glowing. What's going on?
Yeah.
I think to the harm question, though, I think that the main thing, just like any radiation, is that you likely will get some scarring from it, some fibrosis that might slightly increase, risk with surgery and slowed healing with surgery. So, healing is always going to be worse after radiation, and that whether it's brachytherapy, whether it's rhenium, or external beam, doesn't matter. You're going to have that same potential. But I think that for, small, shallow, low risk lesions, I think that this is probably going to be promising, simple, and it will be similar kind of cases as what you can use the superficial radiation for.
Well, let's transition again here and come back to our trivia section. So, Dr. Patton, what do you got for us this week?
It's radiation and the silver screen.
Ooh.
I have a really stupid question, but as radiation oncologists, do you guys ever daydream that there would be like some accident and then you would gain some sort of superpower like the Hulk or Spider-Man? I would think about that all the time. Does it ever cross your mind, or no? You've seen too many accidents and nothing cool ever happens.
Pat,
yeah, maybe I'll dream about that tonight, but I've never had such thought.
Yeah.
I think the best you
do.
All right, so that's just me. Good.
All
right, let's move on.
Hope for would be that you'd be able to have sex without having to worry about getting anyone pregnant. That'd probably be the best.
That would be the superpower.
That'd be the superpower.
Again, a problem better addressed surgically. So
less risk. Less cancer.
Ironically, that's part of the reason why we give 2-grade perfraction. They used to do, like in our rad bio course, I don't know about where they do the ram's testicles.
Oh, yeah.
So like we learned they used to give radiation all at once to castrate rams for like sheep farmers, but then if they gave it a 2-grade perfraction, they didn't cause necrosis and dermatitis of the scrotal sac of the rams. So that's actually what a lot of the basis of how we fractionate radiation.
that's funny.
Ram testicles. That would be a normal patent trivia question.
I was just thinking the same thing. All right, well, they would have known that. All right, let's go. 3 questions. Okay, first one. A 2019 HBO series dramatized the nuclear disaster that occurred at this Soviet Union power plant.
Chernobyl.
I got Yvonne on that one.
Yep.
By the way, if anybody hasn't watched that is amazing.
It is a great show.
Yeah.
Yeah, it was great. And I was working with this PA, and I'm like, this series on HBO is fantastic. It's called Chernobyl. And she said, what's it about?
That's scary. It's sad.
Am I that old? Yeah.
I saw some reel the other day that was like asking a teenager about a 15-year-old about 9/11. And they were like, oh, it happened on September 11th. So that's why it's called 9/11.
Yeah.
And they were like, well, how many hijackers were it? They were like, there were hijackers? They honestly thought that the buildings just fell down for no reason.
All right. As any intelligent person knows, Bruce Banner gained his superhuman powers, speaking of radiation accidents, as the result of an accident involving gamma radiation. Which actors besides Mark Ruffalo have played Bruce Banner in Hulk live-action films?
Lou Ferrigno.
That was the TV series. I was going to include it. I may give that to you if nobody else.
The Hulk. He didn't play Bruce Banner. He played the Hulk.
He played the Hulk.
Right. So you're not really right.
I have no idea.
I don't know.
Mark Ruffalo is all I knew.
It was Eric Bana was in this 2003 Ang Lee Hulk movie. And then Edward Norton was the first MCU guy. He just couldn't make it to all the other ones. Mark Ruffalo took over.
Huh. All right.
Matt, I'm giving you a 0.25.
Oh, wait, I'm ahead of Ferris. This could be my first win ever.
We'll see.
You know what? I'm not hopeful about this last one. It's a 2-parter, and it contains a movie spoiler, so everyone be forewarned. It's a really old movie, so you should know this by now. All right, in the second film of the original Star Trek movie series, a major character dies from radiation poisoning near the end of the movie. Part A. Which character dies?
Spock.
It is Spock.
The good of the many outweighs the good of the few.
Yeah, that's very good.
I know the name of the movie too. I'm hoping that's
I was going to say that was my part B. What is the subtitle of Star Trek II?
The Revenge of Khan.
No.
Oh, shoot.
I was
Anyone?
never enough of a nerd to know anything Star Trek, so I'll just take the
Right.
loss on this one.
I know all this stuff, Bruce Banner, cartoons, Star Trek, and that's why, like, Ferris is a chair and I'm not. I think that speaks volumes about, where this stands. It was the Wrath of Khan,
That's what I
not
said.
the Revenge. You said Revenge.
You're close.
Oh. That was also the
All
one
right.
where they put the worms in people's ears
Mhm.
to control their mind. I had nightmares
Yeah.
about that as a kid for a long time.
Yeah.
That's actually the secret to being a chair too. So, maybe it did come out.
Mind control with worms. Yeah, that works.
Exactly.
That works.
We're gonna base all of your compensation on non-work RVUs. Okay, that would be fine. That's fine. All right. Well, I want to thank Dr. Mowry and Dr. Patel for joining us today. This was a really fun discussion, and I honestly feel like I understand radiation therapy for skin cancer much better now, and I understand much better about what you guys actually do as radiation oncologists. So I really want to thank you guys for coming on. Dr. Patton and Ferris, any last comments for our guests?
I feel like you have a thing in common with dermatologists. I think radiation is given Monday through Friday because we all like the same schedule. So
Well, thank you for having us. It was a pleasure.
Thank you for having us.
Oh, you're welcome. And I want to thank everybody for joining us today. And it really is a fun thing to think about our multidisciplinary care for these patients. And if you've got questions, comments, or ideas for topics we should cover on the show, shoot us an email at questions@dermsondrugs.com. We hope you learned a few things. We hope you laughed once or twice. Mostly, we are hoping you're planning to join us next week. And until then, I'm Matt Zyrus.
I'm Tim Patton.
I'm Laura Ferris, and we are Derms on Drugs.